Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 472 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. The first case reads, PKJ, a 46-year-old man, has diffuse large B-cell non-Hodgkin lymphoma, abbreviated as NHL, in first relapse after a complete remission of 1 year. An 80% reduction in measurable disease is noted after 2 cycles of dexamethasone, high-dose cytarabine, and cisplatin, abbreviated as DHAP, salvage chemotherapy. PKJ's bone marrow biopsy and lumbar puncture are negative for malignant cells. Is a myeloablative preparative regimen with autologous hematopoietic cell transplantation indicated for PKJ? Autologous hematopoietic cell transplantation is used to treat a variety of malignancies. Non-Hodgkin lymphoma and multiple myeloma are the most common indications for this procedure and represent more than 2/3 of all autologous hematopoietic cell transplantation. Nearly all patients who undergo autologous hematopoietic cell transplantation have failed standard chemotherapy regimens. Therefore, their hematopoietic stem cells have been exposed to prior chemotherapy, leading to less abundant and viable stem cells. The primary use of autologous hematopoietic cell transplantation is in diseases that have aggressive features but are still chemotherapy sensitive. In a randomized, controlled trial, autologous bone marrow transplant (BMT), compared with conventional chemotherapy with high-dose cytarabine and cisplatin, resulted in a 5-year event-free survival of 46% versus 12%, respectively, with a p-value equal to 0.001. Overall 5-year survival was 53% in the BMT group and 32% in the conventional chemotherapy patients, with a p-value equal to 0.038. Whereas hematopoietic cell transplantation is delayed until relapse after primary treatment in non-Hodgkin lymphoma, in some malignancies, autologous hematopoietic cell transplantation is indicated as primary therapy to improve overall survival and progression-free survival. Prospective studies comparing preparative regimens, stem cell mobilization techniques, and stem cell source, i.e., BMT versus PBPCT, are not available. However, autologous PBPCT has become the preferred source of stem cells, most likely owing to the improved outcomes with PBPCT in other disease settings. PBPCs, defined as cells that express the CD34 antigen, e.g., CD34+, are continuously circulating in the blood. However, their numbers are too low to easily collect the amount needed in transplant. Mobilization refers to the techniques used to move the stem cells out of the bone marrow compartment, increasing their numbers in circulation. Mobilization can be accomplished using growth factors or chemotherapy. See Mobilization and collection of autologous peripheral blood progenitor cells section. PKJ has minimal residual disease that has demonstrated chemotherapy sensitivity, i.e., he had an 80% response to chemotherapy. His long-term prognosis will be improved with autologous PBPCT rather than with further conventional chemotherapy, as described previously. Thus, autologous PBPCT is indicated, owing to the greater likelihood that higher dose chemotherapy may eradicate his tumor. My next question to you reads: what is the best way to harvest and preserve harvested hematopoietic stem cells for PKJ? Peripheral blood progenitor cells, abbreviated as PBPCs, have essentially replaced bone marrow as the source of stem cells at many hematopoietic cell transplantation centers, accounting for 98% of autologous transplants in adults from 2004 to 2008. Peripheral blood progenitor cells result in more rapid engraftment than bone marrow and fewer days of neutropenia. Collection of peripheral blood progenitor cells occurs before administering the preparative regimen. Thus, autologous hematopoietic stem cells must be cryopreserved. Hematopoietic stem cells are frozen below -120 degrees Celsius and used within a few weeks, although, when frozen, they are viable for years. Dimethyl sulfoxide, abbreviated as DMSO, is the cryopreservative commonly used to protect hematopoietic stem cells from damage during freezing and thawing. Infusion of hematopoietic stem cells stored in dimethyl sulfoxide can be associated with toxicities due to the dimethyl sulfoxide itself. During infusion, dimethyl sulfoxide is associated with skin flushing, nausea, diarrhea, dyspnea, hypotension, arrhythmias and, rarely, anaphylactic reactions. The presence of undetectable tumor cells in the transplanted cells contributes to relapse of hematologic cancers. Unfortunately, purging the grafts of tumor cells does not improve survival. Relative to bone marrow harvest, collection of peripheral blood progenitor cells requires less invasive collection methods and contains up to 5 times more hematopoietic stem cells. This results in a peripheral blood progenitor cell hematopoietic cell transplantation having more rapid neutrophil and platelet recovery, i.e., a shorter duration of neutropenia or thrombocytopenia, fewer platelet transfusions, fewer days of intravenous antibiotics, and a shorter duration of hospitalization compared to a bone marrow hematopoietic cell transplantation. Thus, the shift to the use of peripheral blood progenitor cells instead of bone marrow for autologous hematopoietic cell transplantation is primarily because of the more rapid engraftment and less invasive collection methods. Therefore, it would be best for PKJ to undergo pheresis for peripheral blood progenitor cell collection. These cells would be bathed in dimethyl sulfoxide and frozen at -120 degrees Celsius. For peripheral blood progenitor cell mobilization, PKJ received 1 dose of cyclophosphamide 4 grams per meter squared IV on day 1, followed by filgrastim 10 micrograms per kilogram per day subcutaneously beginning on day 2 and continuing through completion of pheresis. 12 days after receiving cyclophosphamide, PKJ's white blood cell count recovered to 3,000 cells per microliter and pheresis was begun. An adequate number of peripheral blood progenitor cells is collected after 2 pheresis sessions. PKJ's cells are processed and stored. What was the rationale for administering fulgrastim and cyclophosphamide? What determines the duration of pheresis? Normally, low numbers of peripheral blood progenitor cells are found in the peripheral circulation. Therefore, it is necessary to mobilize peripheral blood progenitor cell from the marrow compartment into the systemic circulation. Mobilization leads to a collection of sufficient numbers of autologous peripheral blood progenitor cells in most patients, although a minority of patients may still have poor mobilization. Multiple methods can be used to mobilize peripheral blood progenitor cells. Hematopoietic growth factors alone or in combination with myelosuppressive chemotherapy are used to mobilize peripheral blood progenitor cells. After administration of the mobilizing agents, the patient undergoes pheresis, an outpatient procedure similar to dialysis in order to collect peripheral blood progenitor cells. Granulocyte macrophage colony stimulating factor, that is GM-CSF, or sargramostim, and granulocyte colony stimulating factor, that is GCSF, or fulgrastim, are both hematopoietic growth factors and are used as mobilizing agents for peripheral blood progenitor cell collection. Both reliably mobilize peripheral blood progenitor cells, with fulgrastim providing a higher peripheral blood progenitor cell yield. The most frequently used fulgrastim doses for autologous peripheral blood progenitor cell mobilization are in the range of 10 to 24 micrograms per kilogram per day subcutaneously. Peripheral blood progenitor cell yield is higher when pheresis is started at day 5 versus day 6. With the optimal yield being around 10 hours after fulgrastim administration. Myelosuppressive chemotherapy stimulates stem cell and progenitor cell proliferation. The combination of chemotherapy with fulgrastim enhances peripheral blood progenitor cell mobilization relative to fulgrastim alone. A benefit of using chemotherapy is that it also treats the underlying malignancy. Examples of peripheral blood progenitor cell mobilization chemotherapy regimens include single-agent cyclophosphamide or melphalan. No mobilization chemotherapy regimen is clearly superior, which has led to incorporating peripheral blood progenitor cell mobilization into a cycle of disease-specific chemotherapy, such as using a single cycle of RICE, an abbreviation for rituximab, ifosfamide, carboplatin, and etoposide therapy as the mobilization regimen for an NHL patient whose disease is responsive to rituximab, ifosfamide, carboplatin, and etoposide treatment. By administering chemotherapy to the patient, the body's repair mechanism accelerates the cell division of stem cells and releases them into the circulation. This is a delicate balance, because the more the chemotherapy that is given to mobilize the stem cells, the greater the potential for damage to the stem cells and a decreased yield at collection. Stem cell toxic agents, such as carmustine, should be avoided because they lower the quantity and quality of peripheral blood progenitor cells. The hematopoietic growth factor is initiated 24 to 72 hours after completion of chemotherapy. Pheresis begins when the peripheral WBC count recovers to greater than 1 to 3 times 10^3 cells per microliter. Certain patients fail to mobilize sufficient peripheral blood progenitor cell due to extensive prior therapy or therapy with marrow-toxic agents. In these patients, plerixafor, an inhibitor of the CXCR4 chemokine receptor, can be used. Plerixafor was approved by the U.S. Food and Drug Administration in 2008 for use in stem cell mobilization in conjunction with filgrastim. It is known that CD34 is an adhesion molecule involved in promoting adherence of hematopoietic stem cells to the bone marrow microenvironment. Stromal cell-derived factor 1, abbreviated as SDF1, is a chemoattractant agent for hematopoietic stem cells. Its presence in circulation causes rapid migration of these stem cells to the peripheral blood. Inhibition of the CXCR4 by plerixafor blocks the ligand SDF1 from binding to the CXCR4 receptor, thus releasing CD34+ cells from the bone marrow. In 2 randomized studies, 59% of non-Hodgkin lymphoma patients and 72% of multiple myeloma patients had sufficient CD34+ cell collection for autologous transplant using plerixafor and filgrastim in 4 or fewer pheresis sessions, compared to 24% and 34%, respectively, in those using filgrastim alone. Plerixafor is administered to the patient approximately 10 to 18 hours prior to each pheresis, beginning 4 days after initiation of daily filgrastim 10 micrograms per kilogram. Pheresis is continued daily until the target number of peripheral blood progenitor cells per kilogram of the recipient's weight is obtained. Typically, 1 to 2 large volume pheresis sessions are needed to collect adequate numbers of CD34+ cells. For adult recipients, the number of cells infused that are CD34+ is the most reliable indicator of an adequate peripheral blood progenitor cell collection and predictor of durable engraftment. A variety of different thresholds have been identified as the minimal number of CD34+ cells needed for an autologous PBPCT to produce rapid and complete, i.e., white blood cells, red blood cell, platelet, engraftment in adults. The minimum threshold range has varied from 1 to 3 times 10^6 CD34+ cells per kilogram of recipient weight, with more rapid platelet and neutrophil engraftment occurring with greater than or equal to 5 to 8 times 10^6 CD34+ cells per kilogram of recipient weight. There are a number of factors that can affect the yield of CD34+ cells, including the timing and amount of myelosuppressive treatments received prior to mobilization. Both chemotherapy and radiation negatively impact mobilization. The type of chemotherapy, number of different regimens, and overall duration of chemotherapy treatment affect the ability to collect stem cells. Additionally, hypercellular marrow and refractory disease can lead to a poor peripheral blood progenitor cell harvest. There is a paucity of information regarding the parameters associated with engraftment in children undergoing an autologous peripheral blood progenitor cell transplantation. After pheresis, the cells are cryopreserved, stored, thawed, and infused into the patient as described in the Harvesting Autologous Hematopoietic Stem Cells section. Because PKJ has been in remission for a year after initial treatment for his disease, he received no radiation treatment, and his salvage therapy did not contain alkylating agents. His cell collection can be expected to be good and of short duration. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 473.